All right. So good afternoon, everyone. Welcome to the South Texas Regional Family Medicine Grand Rounds. Next slide, please. So thank you in advance for muting your microphone once the presentation begins, being attentive to the presenters and engage in the session, keeping your cameras on when appropriate, registering for CME credit for each session, and completing and submitting a session eval form. Next slide, please. So here's the activity code for today. To get credit, just text your email address to the number and then text attend 10093239. And you have till midnight to get your CME credit. So I'll leave the slide up here for a bit for you all to get your credit. All right, next slide, please. And again, this is just information how to get CME credit via text. Next slide, please. And then this is just information regarding your CME transcripts and how to get those. Next slide, please. And then this is just information regarding the AAFP credit system. Next slide, please. And then these are the core competencies that the Grand Rounds addresses. Next slide, please. And Dr. Johnson has no financial relationships with an eligible companies to disclose. And next slide, please. All right, Dr. Nato.
All right, well, it's a pleasure to introduce Dr. Ryaja. John works closely with physicians and nurses and other medical providers to deliver care to culturally and age-diverse patients in primary care and hospital settings. Dr. Johnson has provided medical education related to psychological, behavioral change principles to residents and fellows in family medicine, internal medicine, OBGYN, and podiatry. Currently, Dr. Johnson is an assistant professor in the Department of Family Medicine and the Department of Anesthesiology, Pain Management at the University of Texas Medical Branch. As a clinical psychologist and behavioral health consultant, she provides psychological and behavioral health interventions to patients experiencing life stressors, mental health concerns, and difficulty managing chronic medical conditions. She works closely with family medicine residents and anesthesiology fellows on behavioral science techniques and skills to improve patient interaction and health outcomes. Dr. Johnson earned a Bachelor of Arts in Economics at UC Berkeley, a Master of Business Administration and Acquisitions and Contracts Management from the Naval Postgraduate School, a Master of Arts in Organizational Leadership from Chapman University, and a Doctor of Psychology in Clinical Psychology with a Health and Rehabilitation and Primary Care emphasis from Wright State University. Dr. Johnson is an ardent believer in addressing the whole person health promotion with behavioral modifications, cognitive reframing, physical reconditioning, and spiritual coping for people concerned about quality of life disruptions. I would like to introduce Dr. Johnson.
Thank you so much, Dr. Nato, for that introduction. Before I get started with my presentation, I do just want to send out a special thanks to Dr. Obaid for presenting this opportunity to me, as well as Kelsey, who has been so gracious to answer my numerous emails that I've sent over the past couple of weeks. So thank you all for your support and for allowing me to be here today to share with you. So we're going to jump in and talk about non-pharmacological interventions for chronic pain. I would like to, before I get too involved in what I have to present, I would just like to hear from the residents your comfort level with non-pharmacological interventions. We can just, let's say, I'll give 3 options: comfortable, somewhat comfortable, not comfortable. So if you can just provide me some feedback, that'll be helpful.
Somewhat comfortable.
Okay, we have somewhat comfortable. Anyone else? I guess the mic isn't super close to people.
Here. Oh, but I'll just go back here. Yeah. The mic.
Yeah, it's just be helpful to have a little bit of interaction. Makes the time go by. And I definitely want to, be of benefit to you. So any feedback you can provide along the way would be grateful. So we have a somewhat helpful. Anyone else willing to share?
And I say somewhat comfortable because I don't know how well some of maybe my ideas work.
Okay. No, I appreciate that because that's a relevant point, and we can definitely talk about that. All right, well, I'm going to just go ahead and move on then. So today the objective is to provide and explore the impact of chronic pain, describe the need for non-pharmacological pain treatment, and we're going to spend the bulk of the time with the effective brief interventions that you can deliver during your medical appointments, and then kind of summarize the evidence-based information with regards to the efficacy of non-pharmacological interventions. So the chronic pain is a huge issue in the United States. There's numerous studies have been done, and basically roughly 116 million adults, and that's more than folks who are dealing with heart disease, diabetes, and cancer combined, are living with chronic pain. And they estimate that the annual cost of those 116 million people is anywhere between 560 billion to $635 billion annually. And then chronic pain is substantially impacts not only the physical, which clearly everyone knows, but also it impacts the mental functioning of people, their productivity or the lack thereof, their quality of life, as well as relationships. And those, when you say relationships, that can be any type of relationship, so not necessarily just partners. And when you look at chronic pain, as I mentioned, it's not only the physical, it's also the mental aspects. So folks with chronic pain, up to 85% of the patients are also affected by depression. And of those people who are experiencing depression, they believe that anywhere from 18 to 50%, and I know that's a super wide range, but just depending on the study, they're estimating that between 18 to 50% of those people have had thoughts or actually attempted suicide. So why do we need non-pharmacological interventions for chronic pain? Because it's the leading cause of disability, and typically it doesn't respond well to treatment as usual. So patients suffering from chronic pain-induced depression, they actually exhibit poor diagnosis than folks that just have chronic pain. But not only do they exhibit poor diagnosis, the pain slows the recovery process, and there's actually like a bidirectional. So depression may make the pain worse, and pain makes the depression worse. Those combined make it very difficult to treat. chronic pain. And everyone knows about the opioid epidemic, and many studies have come out that cited that the misuse of opioids has really made people start rethinking the care as usual with regards to prescribing medication for chronic pain, specifically opioids. And primary care, so you as primary care residents, you find with regards to, patients presenting in the clinics. So over a third of the patients who present to primary care clinics have some sort of complaint about being in chronic pain. And I asked earlier with regards to the comfort level of how you feel about treating folks with chronic pain. There was a study done that said that the primary care clinicians, they don't feel like they were adequately trained to treat chronic pain, which also causes a lot of frustration, and they don't feel, as one person said earlier, that they don't know if what they're doing is actually helping at all. So the management of chronic pain should include any other type of illness or disability. So like depression. So if you have a chronic pain patient, you should consider thinking about like assessing whether or not they're experiencing some sort of mental that can actually inform your treatment planning with the patient. So we're going to talk a little bit about what you can do in the room with the patient, but I did just want to touch on some other things. So cognitive behavioral therapy for chronic pain is kind of like the gold standard non-pharmacological treatment for chronic pain besides physical therapy. So like physical therapy is typically number one. Cognitive behavioral therapy for chronic pain is a close second. So I wanted to mention this because if you are referring your patients to behavioral health consultants, it's important that you understand for yourself just kind of a general overview of what is cognitive behavioral therapy for chronic pain so that you can explain it properly to your patients. So cognitive behavioral therapy for chronic pain really focuses on cognitive things. So what are the patients thinking, those pain thoughts, and being able to identify those thoughts and help to reframe. And then also it is behavioral. So it focuses on activity pacing, relaxation, doing pleasurable things. And one of the most important things is there is education about what is chronic pain, how do you treat it, because there is a difference between acute pain, chronic pain, and patients don't kind of always know that difference and know that there are different treatments depending on whether or not the pain is acute or chronic. And goal setting, helping the patients kind of visualize what they want to achieve in the future. So kind of helping them to think beyond the pain, to what is it that you want to do to kind of help make your life a little more fulfilling in spite of the pain. So setting long-term and short-term goals with the patient. So do you have any questions about cognitive behavioral therapy? And I should throw out that it is brief. It's 6 sessions, typically, you know, in the primary care setting, depending on the person, could take 30 to 45 minutes per session. Any questions about cognitive behavioral therapy for chronic pain? Okay. So the next thing that I wanted to touch on is self-management. We're going to delve deep into lifestyle changes, so I'm going to hold off on that. But self-management. So there are certain things that the patients can do in order to kind of help with their experience of pain. And some of those things are social engagement, mindfulness practices, meditation, prayer. There are tons of mobile apps. The VA does a great job putting out various apps on CBT types of therapies. There's online support. There are different books. So those are some things that the patients can kind of do on their own, self-initiated type of work that they can do to help with the chronic pain. And so now I'm going to go on to lifestyle changes. And this is where you come in. These are the things that you can do with your patient, that you can talk with your patient about. And it doesn't take a whole lot of time to kind of just go over these interventions with your patient, because you can set, talk to them one appointment, have them set some goals, and when they come back in, ask them about it. And so there is, again, just brief things that you can do in the room with the patient. So the first thing to kind of talk about is that chronic pain is stressful. And patients know that. But what patients probably don't know is how it impacts them, how stress impacts them. So this infogram that I found kind of sums up how stress can actually make the pain experience a little worse, because the blood flow is moving out of the prefrontal cortex into, that emotion part of our brain, which, oh, by the way, is where pain sensory zone as well. And it can cause all sorts of problems. So on the right-hand side, I'm not going to read it to you, but on the right-hand side, it has all the problems that can be caused by stress, and when our brain functions go a little haywire. And what does this do? You actually start, your nervous system starts learning to experience the stress, and the pain experience actually increases. So let's just, and I say all this in kind of like layman's terms, because that's how you really want to speak to your patients in kind of layman's terms, so just so that they understand what's going on with their body. And then you can talk about, okay, so what do you do with all this stress that you're experiencing? So there are some things that you can talk to your patient about that can help manage their stress. So it's kind of like the mind-body interventions. So you're really focusing on the relationship between the physical and mental and how it's impacting overall health. So these are some examples of things that patients may want to start engaging in to kind of help manage the stress level, which will help them to manage any type of pain flare-ups they may be experiencing. So the next thing is that pain impacts sleep. So checking in on with patients about sleep is super important. Researchers have found that shorter sleep times or fragmented sleep can actually heighten the pain experience. Because going back again, kind of using those same pathways in the brain. So this infogram kind of shows that Americans with chronic pain report higher stress levels. We already talked about that. But also, folks who are experiencing pain are more likely to report sleep problems. And folks who actually have sleep problems are more likely to report pain. So again, there's that bi-directional relationship between sleep and pain. So targeting sleeping can be something that you do with your patient. So here are a couple of things that you can talk to your patient about with regards to improved sleep. So avoid daytime napping and expose yourself to natural light during the day. I want to point this one out because that means that they actually have to get up and get out of the house. I know a lot of people who are experiencing pain stay in the house all day. Talking to them about getting out of the house will be of benefit to them. And you may get some, pushback. You can say, hey, you can go, sit on your porch if they have a porch, or just get out the house, just make it a routine to be outside for a couple of minutes, hours a day will be helpful to them. And then also sometimes people who are experiencing significant pain, they're unable to work. So typically when people don't have like a work schedule, they go to sleep any time of day, they wake up any time of day. So their sleep schedule is like so messed up from day to day. So talking to them about getting on a fixed bedtime and wake cycle will be super helpful. And not to just kind of lie in bed all day. So these are just some basic sleep hygiene techniques that you can share with your patient. The screen time, the electronics is a huge thing. So, eliminating that will be super helpful. And then the next thing is deconditioning is something that you can talk to your patients about. So the first thing people tend to do when they're in pain is they decrease, some almost try to eliminate physical activity. So just helping them to understand that leads to the deconditioning of your muscles. So You're no longer as flexible as you used to be. You're no longer, as strong as you used to be. And what does that do? That is actually perpetuating more pain, which can impact your mental health, lead to more disability. Then you have like these thoughts, these automatic negative thoughts, and now you're afraid to move because it hurts, because now your muscles have deconditioned. And so the vicious cycle starts all over again. And one thing that I like to kind of point out, and it is something that's in the CBT for chronic pain, kind of like the difference between hurt and harm, and helping the patients to understand that pain is not always an indicator that you're harming yourself. So harm is like, you're actually injuring yourself or you're damaging your tissues. Just because you're experiencing pain, that doesn't mean that you're necessarily harming yourself. It kind of goes back to the fact that your muscles are deconditioned. So once you start using those muscles again, you're going to feel a little discomfort associated with starting to reuse muscles that you haven't used in a while. So that's something else that you can kind of share with your patients when they talk about how much pain they're in when they move. So this is something that can kind of balance the inactivity that people tend to engage in, and it's called activity pacing. So it's a strategy to really help to limit the amount of physical and mental fatigue that a patient may experience once they start to become a little more physically active. And what activity pacing is that you kind of set a time in which you're going to be active, and then you set a time in which you're going to rest. And depending on how you feel, you can do multiple cycles of activity, rest, activity, rest. It's the one thing that people kind of get into another vicious cycle is if they're in that cycle of inactivity and then all of a sudden they feel great, then they go on the overboard and they try to do all those things on their to-do list that they neglected because they were in pain. And so by going overboard, then they are actually causing themselves to have a pain flare-up, which, oh, by the way, makes them, be laid up for a couple of days for some folks. And so the cycle starts all over. I rest for a while, I feel good, so now I'm going to overdo it. And now I have a pain flare up, so now I'm laid up in bed for a couple of days. And then my to-do list is piling up as I'm laying in bed, so now I have to go overdo it again. This activity pacing kind of helps them to say, okay, we're trying to stop you from having the pain flare-ups so that you don't have to be out of commission for several days. So let's just come up with a plan where you're working for X number of minutes, you're resting for X number of minutes, and you do that cycle, and as long as you feel comfortable, and you always stop before you feel the pain, because we don't want to actually have a severe pain flare-up. So I think that this activity pacing is a great strategy to share with patients to help them to get the things accomplished that they want to do, but do it in a safe way in which they're not actually causing a pain flare-up to occur. So the next thing that is important that you can talk with your patients about is nutrition. I kind of highlighted the things that I wanted to share with you. So a poor nutritional status, such as malnutrition, and I would like to say in the United States, people can be of average weight or overweight and still be malnourished. So it's not so much like you can physically look at a person and tell they're malnourished, because there's a lot of, vitamin and mineral deficiencies in the United States. So a poor nutritional status such as malnutrition, unhealthy dietary behaviors, and suboptimal dietary intake can play a significant role in the occurrence, development, and prognosis of chronic pain. The relationship between nutrition and chronic pain is complex and may involve many underlying mechanisms such as oxidative stress, inflammation, glucose metabolism, and nutrition is the top modifiable lifestyle factor for chronic non-communicable diseases, including chronic pain. So this is something that patients can be actively engaged in with regards to what are they consuming. And I do understand that there are food deserts out there. Not everyone has access to, the most helpful types of foods, but that doesn't mean that you give up all hope and just eat a bunch of highly processed food items. So just talking to patients about their nutritional intake is really important when you're thinking about managing chronic pain. So this picture kind of shows all the areas in which when you eat food that is non-nutritious and causes inflammation, these are some of the common areas that people complain about pain. And so you may have had, some folks come in with back pain or, sciatica, things like that. And you may have or may not have even thought about, okay, what are you actually eating that may be, causing some inflammation? So it's just something to consider when people come in with various types of pain complaints, asking them about their food intake and the healthfulness of the food in which they're eating. So these are some strategies that you can share with your patients about types of food to eat. So I got this off of like the Oregon Health Authority website, and then on the left, and then the one on the right is from the University of Wisconsin Integrative Medicine. So they provide suggestions with regards to how can you kind of modify what you're putting in your mouth so that you're not contributing to inflammation, which is contributing to your pain experience. So some of the things that people can do is drink more water, eat a more healthful, colorful food. So when I say colorful, I don't mean like the artificial dye type food, but the natural foods, the fruits, the vegetables, the seeds. And then they also suggest eating fermented food that has good bacteria in it. that helps with the immune system as well as bowel movement. The University of Wisconsin Integrative Medicine handout is actually something that I give to my patients, and when we're talking about what are they consuming that may be contributing to their pain experience. So on the left-hand side are things that they can eat more of. On the right-hand side are things to decrease or eliminate from the diet. So it is very helpful to have like concrete things that you can give patients, because just saying, you know, eat healthier, move or exercise, like what that means can be very different to different people. I'm sure that if I ask a room full of people, what does healthy mean? I can get a different answer from every single person. So actually having something concrete to examples to share with patients of the types of foods that they should increase, and also the types of things that they can decrease will be very helpful, as opposed to just saying eat healthier or, you know, increase your fruits and vegetables. Like actually giving them some concrete examples will be helpful. And then the next thing I want to touch on is alcohol consumption. Is something that you can talk to your patients about and kind of assess what their intake is. 23% of chronic pain patients also have a diagnosis of alcohol use disorder. And those who are experiencing moderate to severe pain, they 43 to 73%, again, depending on the research study, present with alcohol use disorder. Individuals who engage in binge drinking, they're actually more likely to misuse prescription opioids. So that's why it's super important to check in with patients who are on pain medications, even if it's not opioids, to check in with them about, okay, what is your alcohol consumption? Because they may be misusing their prescribed medication as well. And then alcohol, the tolerance to the, and I'm sorry, the anxiolytic effects of alcohol can occur under certain learning conditions, and chronic alcohol use can also increase pain. So basically, people become more tolerant, so they're going to need more alcohol to have the same level of pain relief. And having more alcohol in them actually makes them more sensitive to pain. So their threshold for pain actually decreases. So it is super important to talk to patients about alcohol use and the impact of continued use on their pain experience. So this is something that you can share with patients about various ways in which they can go about decreasing alcohol use. But also it's super important to gauge whether the patients actually know what a standard size drink is. Because not everyone actually knows what a standard size drink Because someone can tell you that, oh yeah, I'm only drinking a glass of wine a night. How big is that glass? I've seen some wine glasses that are like 20 ounces. So if they're just drinking, 1 20-ounce glass of wine a night, are they within that recommended amount for the week? Maybe, maybe not. If they're doing it nightly, they're definitely not. So doing some education around what is a standard drink size, and then talking to them about, okay, what are some things that you can do to decrease the amount that you're drinking in a safe way. If a person is addicted to or dependent on alcohol, you definitely don't want them to cold turkey stop. But having helping them to build support, get into treatment will be helpful, just kind of depending on where they are. If they are opposed to treatment, there's some things that they can do to kind of slow down the drinking. So writing the reasons why they want to quit, setting a goal for themselves, keeping a diary, watch what they're doing at home, and if there's any temptations in the house, slowing down the amount in which they're drinking. So sipping, rather than gulping, taking breaks in between is helpful. And then learning to say no to those who entice them to drink. This may even include, okay, maybe I need to change up how often I spend with this person that I know is going to, lead me down this road of binge drinking. So just kind of checking in with them on their social engagement around drinking is helpful. So these are just some strategies that you can share in the room with the patient. I think having a discussion about standard size drink can be eye-opening for some patients. And just remembering that one standard size drink per day for a woman is the recommended amount, and 2 standard size drinks per day for a man is a recommended. When I say amount, I mean maximum amount before, you kind of get into an area where there's more concern about their intake. But with people with chronic pain, you probably don't want to hit that maximum amount. You still want to decrease and ultimately, if possible, eliminate the alcohol consumption. So smoking is another thing that is super important, because smoking can be so tricky, because I've heard so many times how, when I'm feeling pain, I have to smoke because it relieves my pain. And that there is actually some evidence for that, in the short run, the nicotine can reduce the pain experience. However, in the long run, it is actually counterproductive, and it impairs the oxygen flowing through, your bones and your muscles, and it actually causes fatigue, and it slows down any healing process that needs to take place. And ultimately, it actually makes the pain experience worse for patients. But I do understand, and I always empathize with the patients, like in the moment, they just want to get rid of, whatever pain they're experiencing. But in the long run, it's unhelpful to them. So 18% of people, adults in the US, smoke according to the Center of Disease Control. And of those who smoke, 50% or more are actually chronic pain, people who seek treatment for chronic pain. And in a recent study, smokers appear more likely than non-smokers to suffer from back pain. So people who come in with back pain, again, kind of assessing, okay, how much nicotine are you consuming? So smokers are 3 times as likely to develop lower back pain than non-smokers. So what can you do to help people who are smoking and they are interested in quitting or reducing the amount of nicotine tobacco that they are using? So there's a 5 A's model that's very common: ask, advise, assess, assist, and arrange. So the first thing is you want to ask your patients about their smoking or their tobacco use, and then advise them about, what I just talked about, the harmful effects of using or consuming nicotine and tobacco, and then assess their readiness to quit. So asking them, what are their thoughts about decreasing or eliminating cigarette use or vaping, cigars, pouches, chew, whatever their particular brand of nicotine intake is. How willing are they to quit or reduce the amount they're using? And then assess their history of any types of attempts that they've had, any medication that they've used, any treatments that they've been in. What were some of the benefits that they saw? What were some of the barriers that they experienced? And if they're unwilling at the time of the appointment to discuss quitting, it's okay. That doesn't mean that you just kind of totally abandon it. You can drop it at that point, but reassess at a later time and ask them, how important is it to them to help to self-manage their chronic pain? How confident are they in their abilities to be an active member in their treatment team with regards to their chronic pain experience? And kind of reassess and go over the healthful benefits of reducing or eliminating tobacco nicotine use. And then arrange follow-up. So for the patients who are willing to quit, you can arrange follow-up with yourself, or if you referred them to behavioral health consultant, check in with the BHC, or the next time the patient comes in, ask them, how has that gone for you with their quit date. And for those who are unwilling, as I mentioned before, just kind of check in with them at the next visit. So those are some of the strategies that you can use in the exam room with the patient. So talking about their stress, their sleep, what their activity levels, their nutrition, their alcohol intake, their nicotine intake. So now I want to just summarize, like, when using these non-pharmacological interventions, how beneficial are they? So the American Academy of Family Physicians, their research suggests that using non-pharmacologic therapies to manage chronic pain is effective not only in decreasing pain and improving function, but it's also effective in reducing longer-term adverse effects of substance abuse, as well as suicide attempts in chronic pain patients. And the Journal of General Internal Medicine, they did a study which was very interesting, where they followed 275,000 active duty military members for 7 years, from 2007 through 2014. And these 275,000 military members were people who actually reported chronic pain. So all of these people in this study were patients with chronic pain. And so what they did with them, they did interventions other than pharmacological interventions. So some of those things included, like, chiropractic care, massage, physical therapy, which is always the, top of the list, but also it included things like movement. So we talked about just kind of safe moving, different types of mind-body meditation types. So what they found is that those who were doing the non-pharmacologic therapies were 8% less likely to experience new onset alcohol and drug disorders. They were 12% less likely to experience suicidal ideation. They were 17% less likely to experience a self-inflicted injury, to include suicide attempts. And they were 18% less likely to intentionally use opioids or barbiturates or some other narcotics, inappropriately use them. So in the study done, this was more so like a literature review looking at a plethora of studies done on non-pharmacological treatment for chronic pain. So the Agency of Healthcare Research and Quality did this particular one was published in 2020, but the research was completed in 2018. And they looked at 233 randomized controlled treatment studies, and they found that there was no evidence suggesting that there was any serious risk related to treating patients with non-pharmacological interventions. And they also found that patients largely had experienced the effects of the treatment after it ended. So like patients who engaged in exercise, mindfulness practices, CBT, and other mind-body types of practices, they experienced the effects of those treatments well beyond the end of the treatment. So this, again, kind of shows that using non-pharmacological interventions, not only does it not harm patients, but it actually helps patients well beyond the time of, the intervention itself. So that is the end of my presentation. And I just want to encourage all of you to consider using some of the things that I presented today. Don't feel like you have to kind of do everything, but depending on the patient, there's always something that you can kind of target with the patient and discuss with them and give them some strategies in which they can use and be an active, engaged member in their own treatment team when it comes to chronic pain. I know we are a little short on time, but if anyone has any questions, comments, need clarification, please feel free to speak. Okay, doesn't seem like anyone has any questions, so I definitely appreciate your time. And I guess I will turn it back over to you, Kathleen.
Yes, thank you so much.
You're welcome.
So, Dr. Johnson, thank you for the informative talk. I really appreciate that. That rings very positively here. We've got as you know from your interactions with Dr. Obaid and perhaps Dr. Johnson Esparza, we've got a very well-developed BHC component here, and so this has been very important for the care of our patients. So, thank you for the presentation.
You're quite welcome. Thank you for having me. I hope everyone enjoys the rest of their day.